Okay, well, we'll take us home here. Last talk of the morning, we'll talk about CT and MRI of focal liver disease, some disclosures. When we talk about focal liver disease, we have to think about two populations of patients because the differential diagnosis is vastly different between these two groups. So the first question we have to ask whenever we approach mass in the liver is the patient cirrhotic? If the patient's cirrhotic, they're at risk for developing hepatocellular carcinoma, or the patient has a history of hepatitis B. They don't have to be cirrhotic to have a risk of HCC and hepatitis B. So hepatitis B patients and cirrhosis, we think about, is a mass HCC or not, or possibly cholangiocarcinoma. And everyone else, kind of non-cirrhotics, people, we will try to tell whether this mass has typically benign features or does it have some other features that we should look at more closely. So let's just briefly talk about cirrhosis. It's a screening. When we image these patients, we often image them on a very regular basis. Based on expert opinion, these patients have between 1 to 3% chance per year, or depending, may have up to 5% chance per year of developing a life-threatening hepatocellular carcinoma. So again, these are cirrhotics, people with hepatitis B, other diffuse liver disease that are fairly severe. And in many institutions, we use a system called NYRS, the Liver Imaging Radiology and Data System. This stratifies people based on risk, and mainly we're looking for LIRADS 4 and 5, the probably hepatocellular carcinoma and the definite hepatocellular carcinoma groups. These have fairly straightforward criteria. They're listed here, but they're very nicely described in the ACR guidelines. I'm not going to go through all of the features exhaustively, but the major point is to be called a definite hepatocellular carcinoma, LIRADS 5. It needs to have a mass-like lesion with arterial phase hyperenhancement, so that there's definite kind of non-rim hyperenhancement of the lesion plus some other feature. So unless you have arterial phase imaging, you cannot really use the LIRADS system. I say LIRADS, I used to call it LIRADS, but my dictaphone doesn't pick up LIRADS. But if I say LIRADS, it actually prints it really well. So forgive me for calling it LIRADS. It's just the dictaphone trains you on speaking in a certain way. Basically, there's a size criteria. If it's bigger than 10 millimeters and you have either washout or growth beyond a certain point, that's definitely hepatocellular carcinoma. And it's amazing, no biopsy is needed. You just go straight to liver transplantation or go straight to treatment of that lesion without any biopsy taken because the imaging features are so suggestive. If you have a focal mass with arterial phase hyperenhancement in either growth or washout on a delayed phase. And washout is defined as having lower signal or attenuation than surrounding normal liver parenchyma. It doesn't mean it will ever washed in. So the criterion is as long as on a venous or delayed phase is darker than surrounding liver, that's washout. And so I really should have been named something else, but it never had to wash in order to wash out. It could always have been dark. The other thing to look at is the washout appearance tends to occur better if you have a very delayed phase. And the very delayed phase is commonly obtained for MRI. It's a 5-minute delay. So let me show you this example. It's slightly bright on the baseline T1. It definitely enhances on the arterial phase. But on the venous phase, we don't see washout. The lesion became iso-intense to regular liver. It's only on a 5-minute delay that we see the washout. And so the key imaging sequences on this exam, besides the non-contrast, is the late arterial phase and the delayed phase. The portal venous phase is pretty, you get all the veins, but it's actually not that helpful for diagnoses. And so if you had to remove a phase, it's probably the portal venous phase. And this is a pitfall I think many groups fall into. Rather than wait 5 minutes, it's boring for the technologist and the patient to wait for 5 minutes before getting that last scan. But it's very helpful to have that because our washout, it's just clearly more obvious on that phase. And part of the reason it washes out is because there's fibrosis. And this lesion is washing out relative to the rest of the liver. You could say that the rest of the liver is washing in. So the fibrosis has water associated with it. Water takes time to get into fibrosis, or contrast takes time to get into the interstitial water where the collagen molecules are. And so the liver gradually gets slightly brighter in terms of the interstitial water enhancement. And so the tumors become hypodense. The kinetics of the gadolinium agent is identical or virtually identical to that of CT. And so early arterial venous phase, you can see there's not any washout seen. But on a delayed phase, we can see washout fairly clearly, especially with narrow windows of all of these lesions in the liver, potential hepatocellular carcinomas. And so one thing I really would like to drill home is if you have a patient with hepatocellular carcinoma concerns, screening exams or follow-up, just change your protocol for a 5-minute delay. It's not that many patients. It won't affect your throughput very much, but it really does affect the diagnosis for the washout, which is a very critical finding for finding hepatocellular carcinomas. Okay, there are other ancillary features of hepatocellular carcinoma that cannot make this into a definitive NYRS 5 diagnosis, but are very helpful to move up the diagnosis from relatively benign finding to something more concerning. And I think it's helpful to explore these. They're not discussed that often, but I find it very helpful in my own practice to kind of judge whether something is concerning or not. One is mild to moderate, not high, mild to moderate hyperintensity on a T2-weighted sequence. So this patient is hyperenhancing. There wasn't washout. Of course, that's a venous phase, but it's slightly bright, not super bright, but a little bit bright on a T2-weighted sequence with fat set. That makes it a little bit more concerning. Maybe we want to watch that patient more frequently to monitor for tumor. Fat deposition. So fat can occur in hepatocellular carcinomas. So if we see some fat in an outer phase image, where there's loss of signal on the opposed phase scan, we have to wonder whether there's an underlying hepatocellular carcinoma. In this case, it's also washout or rim enhancement. So that's definite NYRS 5 lesion. Restricted diffusion with a kind of dark signal on the ADC map. Of course, that's concerning for hepatocellular carcinoma. Some other benign entities, such as abscess, could also have that appearance, but it wouldn't have the enhancement on the arterial phase scan. And finally, mosaic architecture, involvement of blood vessels, such as it occurs in this case, that's a definite tumor in vein. We would also consider to be concerning. What I'd like to also point out is these nodules occur within a certain environment. So it's not just a nodule, but the background liver is often diseased in the patients where we're trying to screen for hepatocellular carcinoma or other liver lesions. And so we might see a nodule better just because there was iron in the liver, or we might see it better when there's fat in the liver, because the nodules of concern often don't take up the iron. They don't take up the fat. The normal or relatively normal liver parenchyma takes up iron and fat, but tumors tend not to. And so in this case, on the in phase, we have very dark signal compared to the opposed phase. This is an iron-laden liver. And those of us who remember the iron oxide agents, remember that we can see tumors better with the iron oxide there. And so we can see this hyper intense focus very well because the liver has so much iron within it. And so it can be very helpful for us to find tumors. So this is a focal iron sparing lesion. We need to observe that and follow it just to make sure it doesn't grow or change. But iron is a good finding for tumors. This is a focal fat sparing focus. So the